Hello again. I hope you find this module helpful in further explaining the content in the associated course document, along with preparing you for participation in lab. You will find a larger list of objectives on your course document for you to feel confident with after participation in lab. For this module, my hope is for you to feel comfortable with identifying what patients benefit from specific exercise, developing and testing a hypothesis for a preferred direction, discussing similarities and differences between directional preference and centralization, selecting and progressing appropriate exercises, and finally, determining when a patient is able to introduce movement in the opposite direction and how to carry that out. Please come to lab with a list of questions as they arise to aid in your confidence with this material. First, let's start with some background information. In 1956, Robin McKenzie was an apprentice of an already established physical therapist who believed flexion exercises were the best and possibly only way to manage back pain. McKenzie's patient, Mr. Smith, happened to come in that day while Robin was working with another patient, so he waved Mr. Smith to head into the exam room where a patient with knee pain had just left. To Robin's shocking surprise, he found Mr. Smith laying on the table in end range extension. With a nervous voice, thinking he had exacerbated Mr. Smith's symptoms, he asked how he was feeling. "Better than ever," Mr. Smith responded. Without knowing what else to say or do, Robin said that would be all for the day and sent Mr. Smith home. From that came the McKenzie Method of Mechanical Diagnosis and Therapy, or MDT. MDT is an extensive classification system which takes several hours and levels of certification to be proficient in. The current classification system you are learning, the treatment-based classification, has utilized the following principles from MDT. The first and most unique is assessing for symptomatic and mechanical responses to movements and postures. Our subjective exam allows us to create a hypothesis regarding what direction or posture the patient prefers, and then has a structured exam to confirm or refute that hypothesis. There is a specific progression of forces in each direction to follow through examination and treatment with the goal of getting to end range. The final and important principle is to encourage self-treatment and prevention. So where does this method fit exactly into the treatment-based classification system? In the original algorithm, we see the specific exercise classification being screened for as a priority in examination. More specifically, if a patient indicates a strong preference for sitting or walking, and we find centralization or peripheralization with motion testing, the patient is classified as specific exercise. Moving to the most recent update of the algorithm, we see directional preference exercises indicated for those individuals who are appropriate for therapy and have high pain and disability scores with volatile symptoms. This schematic represents how screening for centralization and peripheralization in response to movement is a priority in our examination. Using the language of our clinical practice guidelines, those in the category of low back pain with radiating pain or low back pain with related or referred pain benefit from specific exercise. Before we move on, I want to make sure you are comfortable with the language used. A directional preference is a movement or position that reduces or abolishes symptoms which include pain, range of motion, as well as findings from a neuro exam. Centralization is a phenomenon where pain moves proximal. Central pain may get worse, and your patient should be educated on this. But if movements or postures move symptoms more proximal, that indicates a good prognosis. If the opposite occurs in that pain moves more distally, we call that peripheralization. Movements in this direction are contraindicated. Remember, centralization is always a directional preference, but a directional preference is not always a centralizing movement. Now we are ready to discuss the examination. As mentioned, our subjective history guides our initial hypothesis. Take a second to think about what you might hear from patients that prefer flexion. And how about extension? Once you have your hypothesis, move to your objective exam to confirm or refute. Begin assessing the patient's symptoms response to one movement in each direction. Based on their response, you may perform repetitive movements, approximately 10, or sustained movement at the end range. Based on that response, you may continue through a progression of forces, which have already begun with the patient-generated forces, then patient-generated with self-overpressure, then patient-generated movement with therapist overpressure, and finally, all movement is therapist-generated. Let's look specifically at the flexion progression. Flexion progression begins with flexion in lying, followed by flexion in sitting, flexion in standing with foot elevated, and finally flexion in lying with therapist overpressure. Moving to the extension progression, we have prone lying, followed by prone on elbows, extension in lying, then repetitive extension in lying. Then extension in lying with patient overpressure, followed by extension in lying with therapist overpressure, and finally extension in standing. With all of these movements, to avoid memorizing, consider how gravitational load changes as you move through. As you move through the progression, note how the range of motion and gravitational loads increase and movements go from active to passive. A direction that may be less familiar is lateral forces. This progression begins with patient-generated shift, followed by a therapist-generated shift. There are unique spins from these two motions we will discuss in lab, including a shift while performing a prone on elbows, as well as a shift plus extension in standing, and self-traction with a shift. Though being familiar with the progression of forces is important, feeling comfortable with how to interpret what you are seeing is extremely important. A person is considered to have a directional preference if their symptoms reliably improve after specific movements or postures. They are considered to be a centralizer if two different movements in the same direction centralize symptoms, or motion in the opposite direction peripheralizes symptoms. Another very important point to make is the importance of patient education, especially regarding their expectations. Specific to the exam, explain to the patient that you are trying to find movements that centralize or improve their symptoms. This may mean making the central pain worse, but that is okay because if we can find movements that centralize, they have a better prognosis. Specific to treatment, explain that the increase in proximal pain is only temporary, and that the avoidance of movements in the peripheralizing direction is also temporary. I think we do a disservice to our patients if they leave with the interpretation that moving in any direction is dangerous and something to be avoided altogether. Once their symptoms have calmed down, we will introduce movement in the opposite direction. Also important is discussing the clinical reasoning that guides an exam and treatment. We are interested in two snapshots in time, symptoms during motion and symptoms after. We will use a traffic light analogy in reading this chart to guide us. If patient's symptoms worsen during and/or after, that is a red light and we need to consider moving in the opposite direction. Let's jump down to another easy decision. If patient's symptoms centralize or improve, we keep moving in that direction until further centralization occurs. Now for the less intuitive, the yellow zone. If symptoms increase during but are no worse after, you may consider offloading the spine by going gravity eliminated or by decreasing the range of motion. You may also try movement into the opposite direction based on your initial hypothesis. If you find no effect during and after, consider moving through the progression through increasing range overpressures, or gravitational loads on the spine. If symptoms decrease during but are no better after, I would also consider following the progression or increasing repetitions performed. If you are unable to centralize symptoms in any direction, the patient is then classified under the traction category. The great thing about this approach is our assessment becomes our treatment. We will continue to progress movements towards the end range until complete centralization has occurred. However, we cannot stop there. Once centralization has happened, we may either move within the symptom modulation category to mobilization or manipulation if the pain and disability scores are still high. However, if those scores are low to moderate, the patient then moves to the movement control category, where impairments in muscle performance and regional joint range of motion drives our treatments. Knowing when and how to introduce movement in the opposite direction is something to keep in mind. Generally speaking, after stability of the condition has improved, or if the patient has experienced about a week without peripheralization, you may begin to move in the opposite direction. Some guidelines to help that process include starting in an unloaded position, as well as ending your session with prior centralizing maneuvers. It is also important that you and your patient understand the difference between peripheralization and general soreness. You may also find this chart suggestions helpful. Also, once the condition has stabilized, you may consider other methods of treatment, including neurodynamics, which we will cover later in the semester. I did want to point out that movement control, particularly assimilation or dissociation, is important to screen in these patients. For example, if a patient had once peripheralized with flexion, and you notice that every time they move forward or lift that they round their back, that patient may benefit from learning how to move from the hips instead of moving from the spine. You may also consider the mobility requirements at the hip to allow for more movement to happen in that location versus the back. We will close with some evidence and benefits of this approach. It has been demonstrated that individuals who receive treatments that match their classification show significantly greater improvements than those who are not matched. In fact, 1/3 of patients who moved in the opposite direction ended up dropping out of the study. Benefits of this approach include patient empowerment through education and active self-management, along with the ability for the patient to actively participate in maintenance and prevention. Thank you for viewing this module. Again, I encourage you to create a list of questions that came to you in viewing this module to generate discussion and active participation in lab. I look forward to seeing you soon.